Assalamu alaikum. This is Dr. Mariam Al-Abdallah, and we're gonna continue our talk on removable appliances in orthodontics. Just to remind you with our reference, it's chapter 17 from An Introduction to Orthodontics. Last lecture, we talked about definition of removable appliances, mode of action, indications, general design. We started talking about active components and retentive components. Now we're going to finish the rest of the components, talk about the management of removable appliances, and then show you some clinical cases. So as we said, the components of removable appliances are active components, retentive components, anchorage considerations, and then base plate. Yeah? Some components may contribute to more than one function. Now, let's talk a little bit about anchorage. When we say anchorage, it's not like a specific component like the Z-spring or braided finger spring or Adam's cloth. Anchorage is a concept. It's the resistance to unwanted tooth movement. In orthodontics, we apply pressure or force to the teeth. So this is what we consider action. According to Newton's third law, there is a reaction for every action. The reaction to the orthodontic force is sometimes undesirable, so we need to resist unwanted tooth movement produced by this action. And this is how we measure anchorage. Now, the way to do it is to look at the tooth or teeth that we are trying to move. The root surface area of these teeth will tell us about the reaction, amount of the reaction that we want to resist. So we have teeth that we will move and teeth that should stay still. The teeth that we want to move are called the active unit. The teeth that should stay still are called the anchorage unit. Now, to be able to control anchorage, we have to have as little as possible in the active unit, as much as possible in terms of number of teeth, more root surface area in the anchorage unit. Another thing to do is to divide and conquer concept, which means that instead of moving 3 or 4 teeth at the same time, we can go with 2 stages of treatment, where we move 1 or 2 teeth in the first stage of treatment, and then a second stage to move the rest of the teeth according to the treatment plan. Also, anchorage could be reinforced in orthodontics by using other appliances. For example, like the headgear that we talked about in our last lecture. It's an extraoral appliance that could be used to reinforce anchorage. There are different concepts regarding anchorage, and this will be explained in details in a separate lecture. But since we're talking about it in the removable appliances, it's really sometimes part of the design of the acryl and its contact with teeth. We will cover a little bit on that when we talk about the base plate. So the uses of the base plate is to incorporate both retentive and active components into a single functional unit. So it holds the metal framework all together. It also helps in anchorage and retention of the appliance in the mouth. It should resist unwanted drift during tooth movement, and it distributes the forces from the active components over a large area. This large area could be the teeth that should stay still that we talked about, and this should depend on the root surface area. The larger the root surface area, the more anchorage we get from these teeth. It also depends on the surface area of the acryl and what it covers vertically and horizontally in terms of the anatomy of the palate. Base plate also protects the palatal springs against distortion in the mouth. We said that sometimes the Active components could be made of 0.5 millimeter stainless steel wire, and this is a small thickness, and it could be distorted. And one way to protect them is to build acrylic as a box to prevent distortion and breakages. Sometimes we can modify the base plate to play an active role, like bite plane, posterior bite plane, or anterior bite plane. Now, the base plate is usually made of self-cure acrylic because it's cheaper and it's quicker to be made, although there is more free monomer. And the reason why we choose for the majority of our removable appliances self-cure acrylic is because these appliances are usually made to be used for a very limited time. For example, 6 months, 9 months, and they usually produce light forces, and they are exposed to light to acceptable amount of force. But if I'm planning to use the appliance for a longer time, or the appliance is expected to be exposed to heavy force, then we need to go for heat cure acrylic to give an additional strength to the appliance. Anterior bite plane is one of the modifications that we could apply to the base plate. And what do we do is to increase the thickness of the acrylic behind the upper incisors. We increase the thickness by increasing the depth and increasing the length of the piece of acrylic that is behind the upper incisors. And when the patient is trying to go for maximum intercuspation, usually the lower incisors will bite on this bite plane, and the buccal segment is separated. To have a proper bite plane being built up, we have to have at least 3 incisors in contact with this bite plane out of 4. Because if we have 1 or 2 only, then there will be a traumatic bite and we will have mobility, root resorption, gingival recession affecting the lower incisors. So to have a proper distribution of forces resulting from biting on this bite plane, it's important to have 3 of the incisors at least out of 4 comes in contact with this bite plane during maximum intercuspation. Why do we use it for? As you can see, the lower incisors comes in contact with this bite plane, and what happens to the buccal segment is that they become separated. And now in growing patients, they are free to erupt to fill this gap, and we will end up with reducing the overbite. So it is used in growing patients with deep overbite, increased overbite, because it's very useful and it's an effective way to reduce the overbite. Another situation where we need an anterior bite plane is to free the occlusion to allow tooth movement. Sometimes the occlusion can prevent the wanted tooth movement. So we can separate the teeth, we can open the occlusion using flat anterior bite plane. The bite plane should be flat, otherwise if it's inclined to a certain direction, it will affect the lower labial segment and it will cause unwanted movement. So this is an example of a patient with a classical class 2 division 2 malocclusion, deep overbite, and if we want to insert lower fixed appliance with this amount of bite, it's not possible. So what do? We add a first stage of removable appliance with a flat anterior bite plane, and this is what happens. What happens is that the overbite is reduced, and now we can fit the lower fixed appliance and move on with the rest of the stages of the treatment. What does the technician need to know? Well, in order to build a proper bite plane, anterior bite plane, we should inform the technician about the amount of overjet, because the amount of overjet will determine the amount of bite plane extension posteriorly, the length of the bite plane, how long it should go posteriorly. The bigger the overdid, the longer the extension of the bite plane posteriorly to allow the lower incisor to bite on it. Also, the technician needs to know the amount of overbite. The amount of overbite is important because you can only separate the buccal segment 2 to 3 millimeters. You cannot separate it more than that because the appliance will be uncomfortable and the patient will not wear it. So if the overbite is really deep, then we can have 2 stages of removable appliances. The first stage where we have enough depth of the bite plane to separate the buccal segment 2 to 3 millimeters. And when the buccal segment erupts into that space and come in contact with the upper molars, then we add a new layer of acryl. We build further the anterior bite plane so that we will have another 2 to 3 millimeters of separation, and so on and so forth until we get a proper overbite reduction for those patients. Buccal capping is another modification for the base plate, where we cover the occlusal surface of the buccal teeth. Sometimes we cover it fully, or we cover half of the buccal cusps. Only the palatal cusps, and we free the buccal cusps. The reason why, because it will make it easier to adjust the rest of the components if it's only halfway coverage of the occlusal surface. Why do we need to use it? Well, it is used to open the bite to allow tooth movement. So this is an example of a patient that has a unilateral buccal crossbite with mandibular displacement. So if we want to expand the upper arch using midline expansion screw, this occlusion locks the buccal segment and prevent its movement. So what do? Is that we add posterior capping, or what we call posterior bite plane. And then as the patient activates the midline expansion screw, the teeth can bypass each other and the occlusion is not locked, and we can correct the malocclusion. The posterior bite plane should be thin enough to be comfortable, but thick enough to be strong and avoid breakages. The patient should be warned about a fracture. They should be given instructions on diet and eating, that we will talk about this when we talk about the removal appliance management. So it should cover the posterior teeth so that the anteriors are only separated 2 to 3 millimeters. So it should not be thick. A thick base plate will cause discomfort, a bigger separation of the anterior teeth. As we said, it could be extended only halfway across the buccal segment to assist adjustment of other components like Adam's clasp. And this is an example of an upper removable appliance with midline expansion screw. The wanted tooth movement is to push both buccal segments on the right and on the left buccally. And if there is occlusal interference, then we extend the acryl to cover the occlusal surface of the buccal segment like this. So this is a posterior bite plane incorporated into this design. So when I want to design a removable appliance, I have to go through a specific thinking process. The first thing is this the case that can be corrected with simple tipping movement? I need to know the limitations of my appliance. Removable appliances can only produce simple tipping movement. If this can correct the features of malocclusion that the patient is presented with, then we can use this appliance for this patient. We have to have proper records, especially impression with alginate, in order to construct a removable appliance that can fit accurately inside the patient's mouth. Now, when I think about the actual design, the first thing I need to choose is the active components. So I need to know why I'm using this appliance. What teeth do I want to move and in which direction? And accordingly, I go for my active component. So for example, I have a premolar in crossbite and I want to push this tooth across the occlusion buccally, then I choose T spring. T spring. For example, if I want to distalize the molars on one side, then I use expansion screw, and so on. So I have to know what are you aiming for, and then you choose your accurate active component. After that, you decide on your retentive components. As we said, retentive components, the main aim is to retain the appliance in place. It's important to have at least 3 points of retention. If you have abrupt heavy force, like for example in cases of expansion screws, then you have to use 4 points of retention. Now, it's important also to choose your retentive components so that they do not interfere with the movement of teeth. Again, for example, I'm using a Z-spring on the upper left central incisor. I cannot use a south end on both central incisors because one of them is going to be moved buccally. So this is an interference. This cannot work. Right. Now, after that, I need to think about the anchorage management in that case. I need to know how many teeth I'm trying to move, how many teeth are in my active unit, how many teeth are supposed to stay still, which means the teeth that are in my anchorage unit, and if I need to reinforce anchorage using, for example, headgear or dividing the treatment instead of one stage, two-stage removable appliance treatment, etc. And finally, we decide if my acryl needs modification by adding anterior bite plane or posterior bite plane. So we take the impression, we pour the stone, we have a study model, metal framework is constructed on this study model, then acryl is added to combine and to hold the metal framework together. We modify it accordingly, and then we have our appliance. Now I want to fit the appliance inside the patient's mouth. I need tools. I need instruments to be ready in my clinic. I need Adams plier to adjust the different components, or loop forming plier also to adjust the active and the retentive components. I need a cutter, heavy cutter. I need a ruler and a divider in order to measure references, distances, etc., to make sure that I have a good baseline data. And of course, I can use a straight hand piece with an acrylic bear in case I needed to adjust or modify the acryl. For example, if I discovered that the acryl is in the way of tooth movement, in the path of tooth movement, there is an excess acryl, then I need to trim it. For example, an anterior bite plane, as we said, should be in contact with at least 3 lower incisors. So I take an articulating paper and I ask the patient to bite. And then if there is only 2 out of 3, then I have to trim the acryl until I get at least 3 lower incisors in touch with the flat anterior bite plane. When I receive the appliance from the lab, I need to make sure that this is the design that I requested. And this is the study model for that patient who's sitting in the chair. I need to make sure that the fitting surface is having no roughness or bubbles or any problems that could disturb the patient. And after that, before I try the appliance inside the patient's mouth, I have to show the patient the appliance, explain about the different components, and ask his permission to try it in. And after we fit the appliance, then we give the patient and the parents instructions about how to take care of the appliance, how to fit it, how to take it out, etc. Now, if I try it in and it's not fitting, Okay, not fitting doesn't mean not retentive. Not fitting, it means, for example, it's rocking. The problem could be that there is partially erupted teeth when I took the impression, and now when I want to deliver the appliance, it erupted a little bit further, and now it's interfering with the acrylic. And I use the straight handpiece with the straight handpiece with the bare acrylic bare in order to remove such an interference. Maybe a tooth has moved by the time the appliance has arrived. If there is significant delay between taking the impression and fitting it, especially if the patient is still growing, then there's a general change in the dentition, teeth, soft tissues, etc. So it will not fit. And after that, I check retention. So the first thing, check if it's fitting or not, and then I check retention and I adjust the retention until the appliance is retentive inside the patient's mouth. I adjust the bite plane as necessary, and finally, we adjust the active components. Sometimes the active components are left passive for the first visit until the patient gets used to the appliance, and then the next visit we start activation. This depends on the case, on the patient's age, patient's compliance and cooperation, and accordingly I decide on this step. Of course, when I'm sure that everything is good, I give the patient a mirror and I ask him to look through it, and then I start to insert the patient with insert the appliance inside the patient's mouth, and I use the technique of show and tell. So he has to look at himself inside the mirror and see how we fit the appliance and how we remove it. Now the instructions again, it depends on the appliance. Do I want the patient to wear it full time? Do I want the patient to wear it part time? Is it a gradual increase of the time of wearing it? Do we have an expansion screw that the patient is responsible to open? So the instructions depends really on the appliance and on the case. And before the patient leaves, he should know when his next appointment for review. So the instructions is that the appliance is not maneuvered through the labial bows or springs. If you want to take it out, it's important to go to the posterior bridges, Adam's clasp, for example, something rigid, okay? Because labial bone springs will be disturbed if the patient starts to remove the appliance using them. Now, some appliances the patient should wear full time, 24 hours, during school hours, at night, sport, as long as it's not contact sport, he can wear it. The only time he is not allowed to wear his appliance is if the patient is going for swimming or contact sport. Swimming, because the color of the appliance will make it difficult for the patient to look for it if it is removed from his mouth during swimming. And contact sport, it's a bit dangerous and it can cause trauma. As I said, yes, some appliances the patient can wear 24 hours, and some appliances the patient should wear, for example, all time except for meals, or nighttime and evening and all night. It depends on the appliance. Of course, high standard oral hygiene should be insisted. If the patient should wear the appliance full time, then he should avoid sticky food, hard food, and he should remove the appliance after meal, brush his teeth, clean his appliance, and fit it back in again. It is expected to have some toothaches, headaches due to pressure on teeth and movement of teeth. So the patient can take painkiller based on his weight and age. Some components can cause at the beginning ulcers because these are new inside his mouth. So he can use oral gels for ulcers. And this is temporarily. If it persists, then the patient should contact the clinic and arrange an appointment. I need to give the patient instructions on how to activate the screw if it's part of the appliance. It's very important that if the patient is wearing the appliance part-time, not full-time, to have a proper container or case in order to keep the appliance there. Otherwise, if it's left outside the mouth, it can break, it can be lost, and he will need to construct a new one. Usually the review, again, depends on the case, but it ranges between 1 month to 3 months. Now, when the patient comes back to his review clinic, I can tell if the patient is actually not wearing his appliance. I check the appliance and I find little evidence of wear. If I ask the appliance about how he's been doing, how is the appliance, and he's been talking not without any proper pronunciation, not proper speech, that means the appliance was not inside his mouth properly. If I check intraorally and there are no marks around the different components of the appliance on the palate, that means he's not wearing it. If the appliance is experiencing frequent breakages, that means it's being outside his mouth more than inside his mouth. And of course, if I look inside the mouth and I examine the teeth that I wanted to move and there is no progress, that means the patient is not complying. At each visit, I have to check oral hygiene, I have to measure overjet, overbite, molar relationship, and compare these with the baseline measures and relationships. I need to check loss of anchorage, and usually loss of anchorage is expressed by increasing of the overjet or movement of the anchorage unit toward the active components. So for example, if I want to push the labial segment buccally, the reaction is that the buccal segment will be pushed distally. So I need to check the molar relationship and check loss of anchorage. I need, of course, to check tooth movement, and I can measure the distance from the tooth that I want to move to a tooth that is supposed to stay still, and I compare that with the baseline. For example, I'm trying to distalize the canine, then this distance here should get smaller every visit. I need, of course, to check retentive components, and it's normal to have an appliance that is loose because the patient is supposed to remove the appliance after meals to clean it. So I check the retentive components and retighten them, reactivate them. I need to check active components and again activate them accordingly. I need to check the bite planes and the buccal capping for any fractures or breakages. And then I need to decide on my next visit aims and give the patient a review appointment and so on and so forth. If the patient is experiencing slow rate of tooth movement, then maybe the patient is not really wearing the appliance full time as instructed. Maybe the springs, the active components, are not correctly positioned. Or maybe the active components are being distorted or overactivated. Maybe the acryl is in the way of the tooth path of movement, and so it's preventing tooth movement. Sometimes the occlusion prevents the movement. The occlusion can prevent some types of tooth movement, and this is why using some plates with the acryl can help to disocclude teeth. If the patient is experiencing frequent breakages, then again, maybe because the patient is not wearing the appliance full time. Maybe the patient is having the habit of clicking the appliance in and out with his tongue. Usually the patient, when he gets used to the appliance, he will go with his tongue, suck it out, suck it in, suck it out, suck it in until the components are fragile and we have fatigue within the different components, and then we will have breakages. Or the patient is not following diet restrictions and he's eating sticky food and hard food, and this might break the appliance. Again, if the appliance is getting quickly loose, so for example, I give the patient a 3-month appointment and he comes 1 month later saying that it's loose, it comes out of his mouth, then maybe the patient is playing with the appliance, clicking it in and out, or he's removing the appliance frequently. every time he's being disturbed, the patient is feeling a bit of pain, he removes the appliance, and this is why the retentive components becomes loose. If the patient is experiencing excessive tilting of tooth that I'm trying to move, maybe the force is excessive. Maybe the active components are being distorted. Or maybe the force is further away from the center of resistance. My aim is to have the force as close as possible to the center of resistance, to have a controlled tooth movement. Again, anchorage loss. We worry about anchorage loss, especially for patients who's not wearing his appliance as instructed. They should wear it full time. Part-time wearers can experience anchorage loss. Or maybe the anchorage was not properly planned. An example, for example, I'm trying to distalize the canine. So the canine should be distally moved. The reaction is that the anterior segment moves anteriorly. So if I have proper anchorage, the overjet should not change over the visits. If it increased, that means I have loss of anchorage. The anchorage is not properly planned, or the patient is not wearing the appliance as instructed. Sometimes the patient experience palatal inflammation due to poor oral hygiene, or maybe the fitting surface is causing trauma to the palate, or maybe the gingiva is being trapped between the acryl and between the tooth that I'm trying to move. If the overbite that I'm aiming to reduce with a flat anterior bite plane is not responding, maybe because the patient has stopped growing, because I'm planning this aim only in growing patients, okay? Maybe the patient is having a horizontal mandibular growth instead of a proper rotation. Or maybe the patient is not wearing his appliance. Now, if the appliance experienced fracture, I need to know why it was fractured, and I need to give the patient the instructions to avoid this incident. I need to think about the cost of making a new one or repairing the old one. I need to look at the broken part. Is it a part that I can actually avoid using at that stage? For example, if I have breakages of one of the arrowheads of the Adams, I cut the sharp arm, and then I look at the other arrowheads. Is it enough to give me the retention? If the appliance is retentive, there is enough retention, then I just adjust and reinsert. If the original study model is there and it could be useful for repair, then I can place the appliance on the study model and send it to the lab for repair. Otherwise, I have to insert the appliance inside the patient's mouth, and I take an over impression with the alginate. So I take the impression and the whole appliance will come out with the impression, and I send it to the lab for repair. The repair should not take a long time because I already have a teeth or a tooth that is being moved, so I don't want to have relapse, and I need the appliance to come back as soon as possible so that it can fit properly and continue my treatment plan and continue my tooth movement. Now we're going to talk about some clinical cases to apply this knowledge about URA design. We're going to start with a single anterior tooth in crossbite. So this is a patient in the mixed dentition. The only problem I want to worry about here, the only feature of the malocclusion is the upper right central incisor and crossbite, okay? So can I correct this with simple tipping movement? Yes, so this is the first question. The second question is, what active component can fulfill this aim? Well, for a single tooth and crossbite in the anterior segment where I want to push labially, I can use the spring. Okay, what about retentive components? Once I decided on my active component, I can decide on my retentive components. So the retentive components could be an Adams clasp on the upper left 6. So the upper left 6, we can have Adams clasp, 0.7 millimeter stainless wire. So this is how we communicate with the technician. We need to write the name of my component and I need to draw it. So I'll have a Z-spring on the upper right central incisor, Adams clasps on the upper left 6, upper right 6, and upper right 4, because here the patient is having a 4 fully erupted, so I can use it. And of course, because I'm trying to push a tooth across the bite, the occlusion will prevent this, so I need to add posterior bite plane. Okay. Can I use labial bow? We can use short labial bow, but why if I'm having my third point of retention posteriorly? And this will aid, let's say, aesthetic. The patient will appreciate it that you're not using anterior components. And this will aid patient's compliance as well. So this is how we draw the posterior bite plane, and this is how we communicate with the technician regarding the design. Okay, I write the name of my active component, where I want to put it, and the thickness of the wire. Z-spring force is 0.5 millimeter stainless steel wire. Adams on the molar is 0.7 millimeter stainless steel wire. On the premolar, 0.6 millimeter stainless steel wire. Just to remind you, this is how a Z-spring will look like inside the removable appliance. It's a 0.5 millimeter stainless steel wire. This is the general idea. Now these teeth are colored blue because there is a posterior bite plane. So when we activate the Z-spring, it should push the tooth across the bite and correct the anterior crossbite. So this is the patient before, and this is the patient after, and this is the only feature I'm trying to correct, just simple tipping movement. I would not use the removable appliance for rotational movement because it's not possible. Another case is a patient with 2 adjacent anterior teeth in crossbite, like this. So again, the first question, can I correct this with simple tipping movement? Looking at the teeth and their orientation, yes, I can. What is the active components that can produce such movement? Well, again, it's a Z-spring, double cantilever, modified so that the active arm is longer, and we modify the thickness and use 0.6 millimeter stainless steel wire. And after that, I decide on the retentive components. So I'll have a double cantilever on the central incisors to correct the anterior crossbite. This is 0.6 millimeter stainless steel wire. I can have double Adams on the 6th and the E. You can see this is the E. On the 6th and the E, and this is a 0.7 millimeter stainless steel wire. And then Adams on the upper right 6, 0.7 millimeter stainless steel wire, and another Adam. Oh, sorry, there were 1, 2, 3. Oh, yes, this is enough. And then we can use another Adam on the upper right 4 of 0.6 millimeter stainless steel wire. And of course, because the teeth are in crossbite and the occlusion will prevent their movement, it's important to go for posterior bite plane. So this is a reminder of the active components. So we have double cantilever. Some books will use separate Z-springs, one on the left side, one on the right side. Well, this is not being advised because if you have a little bit of different activation between these two centrals, the patient will not appreciate to have 2 centrals of different position. Okay, one double cantilever you will activate it at once, and it will move the teeth equally, and it should not produce different tooth position at the end of the treatment. So this is the patient with the crossbite before, and this is after, and only simple tipping movement was used. Another case is when we have more than 2 anterior teeth in crossbite. If you have more than 2 anterior teeth in crossbite, you cannot use Z-spring or double cantilever. You have to use something else. It is the anterior expansion screw, because now you want to move blocks of teeth. So we use anterior expansion screw, and this is where we cut the appliance. We cut it from the C to the C on the other side. Okay. This is my active component, and then we use the expansion screw. We we draw it with two lines like this. And then for the retention, I can use Adams on the upper left 6.7 millimeter stainless steel wire, double Adam on the other side of 0.7 millimeter stainless steel wire. And because my active component is an expansion screw, the advantage is that on the active unit, I can add retentive components. It does not interfere with the tooth movement, so I can use south end on both central incisors as an anterior retentive component. South end is 0.7 millimeter stainless steel wire. And of course, because the teeth are in crossbite and the movement of teeth will be interfered with the occlusion, it's important to go for posterior bite plane. So this is generally speaking, posterior bite plane, anterior expansion screw, and I give the patient instructions to open it once or twice a week. And this is how the blocks of teeth will move. And this is how the south end is not really preventing its movement. Okay, let's see again. So the patient is expanding it, and the south end is not preventing it because the acryl is being cut here, and the whole unit, this piece of the acryl, the whole thing is moving labially. So this is the patient before and after. Another case is a closure of diastema, and another name for the type of anchorage that is presented is the reciprocal anchorage. Okay, so this is a patient with big diastema. The child is being disturbed aesthetically with this diastema. Then I need to think about closure of this diastema. So can I do this with simple tipping movement? As long as the incisors are mesially inclined or upright, then it's possible to tip both of them toward each other. But if the incisors are mesially tipped, I cannot do this. Okay, for this patient, luckily, it's possible to go for simple tipping movement. So the first thing I need to think about is what active component can move these central incisors within the line of the arch mesially. Now, the only active component that can do this is the palatal finger spring. So I'll have a palatal finger spring on the upper right central and another palatal finger spring on the upper left center of 0.5 millimeter stainless steel wire. And then I can decide on the rest of them of the active components. Adams clasp on the 6s of 0.7 millimeter stainless steel wire, Adams clasp on the Ds of 0.6 millimeter stainless steel wire. Or I can use, I don't have to use both Adams on the Ds. I can use it on one side. It will be enough because I'll have 3 points of retention as long as the undercut is adequate for retention on the Ds. Because the deciduous molars usually have poor undercuts and the retention really is not that adequate. It's not that good. Right. So is moving the incisors mesially interferes with the occlusion? No, it does not interfere with the occlusion, so I don't need to add posterior bite plane. I don't need to add posterior bite plane, okay? I can use alternatively, instead of having Adams on the Ds, if the undercut is not adequate, I can have labial bow from 3 to 3 as an alternative, okay? 0.7 millimeter stainless steel wire. Is it possible to go for a labial bow if the incisors are having palatal finger springs? Yes, because the labial bow will not interfere with the type of tooth movement. That is mesial movement of the incisors. So this is just to remind you with the active components. This is how the palatal finger spring will show after the patient fits the appliance. Only the active arm will be visible. The rest of the component will be hidden inside the acryl. Okay, so this is two palatal finger spring with labial bow, so it doesn't interfere with the retention or with the tooth movement. Another case is the unilateral crossbite with mandibular displacement. Unilateral buccal crossbite with mandibular displacement. So this is a patient with a crossbite on the left side. You can see the mandibular displacement and the facial asymmetry. And the patient is in the mixed dentition. So the appliance of choice to correct this problem is to have a midline expansion screw to push the teeth across the bite. Now, the problem is not on the left side only, it's on the left side and the right side. But what happens is that as the maxilla is narrow, symmetrically narrow, the mandible will be confused where to bite, and eventually it will choose one side, and we will have mandibular displacement to avoid premature contact. So if there is no mandibular displacement, then the problem is only on one side, okay? And the design of the appliance should be different. But for this patient, we have mandibular displacement, then we have to go for a midline expansion screw where the acryl is cut exactly in the middle. So we have a midline expansion screw, we have 4 points of retention, we have posterior bite plane, and as the patient activates the appliance, the maxilla will be expanded. So again, if the patient has only crossbite, no mandibular displacement, for example, on the left side, then the cut of the acryl should be closer to the problem. The cut should be here, not in the midline, and the acryl should extend to include all teeth so that I will have a small active unit and a huge anchorage unit to resist unwanted tooth movement, because I want only this segment to move buccally. I want the other segment to stay still, okay? This is, as I said, in case I have unilateral crossbite without mandibular displacement. But if I have mandibular displacement, then the acryl should be cut in the middle. I should have a midline expansion screw right in the middle, and I'm going to push both buccal segments buccally. And this is what we call reciprocal anchorage. So this is the action, buccal pushing of teeth, and this is the reaction of, and both of them are desirable. I don't need to resist unwanted tooth movement. I don't need to resist this, so this is called reciprocal anchorage. If I have a single posterior tooth in crossbite, then I can use removable appliances. For example, here, for this patient, I just want you to focus on the crossbite on the upper right 5 and the crossbite on the upper right lateral incisor. The first question is it possible to correct this with simple tipping movement? Yes, it's not that severe. The orientation of the lateral allows further proclination and pushing across the bites. For the lateral incisor, what's the active component? It's a Z-spring of 0.5 millimeter stainless steel wire. For the second premolar, I choose T-spring of 0.5 millimeter stainless steel wire. For the retention, I can clasp the 7s using Adams clasp of 0.7 millimeter stainless steel wire. On the left side, I chose 7 because 6 happened to be extracted. So I need to make sure that the technician knows that this is a 7 and we need to clasp it. On the right side, why didn't I clasp the 6? I went all the way back to the 7. Well, because I'm trying to push the 5 across the bite. And a T-spring there with an Adams at the same time crossing the contact point between the 5 and the 6 is a crowd, okay? It can prevent tooth movement. So I have to make sure that there isn't other components that may prevent tooth movement. So a T-spring here is enough. Since the 7 is fully erupted, I can use it for retention. These are only 2 points of retention. I need a third point, and the third point is Adams on the 4 on the left side. Why not on the right side again? Because it will interfere with the movement of the 5. Okay, these are my 3 points of retention, and because the movement of tooth will be interfered with the occlusion, I need to separate the occlusion. Why didn't I use anterior bite plane? Because the patient's overbite is average, and because the patient is an adult. As you can see, the 7 is fully erupted. That's it, the patient is not growing, she's an adult. The alternative is to have Z-spring on the lateral, T-spring on the 5, and instead of having Adams on the 4, we can have labial bone. But again, as I said, the patients really appreciate it if the appliance inside their mouth doesn't show. So you can avoid anterior component if possible, but if it's the only source of retention, then of course I have to use them. So I can use labial bow 3 to 3. An alternative is to use, so this is the third alternative, as you can see, the active components should be chosen correctly, and then the retentive components we can have alternatives according to the case. Here, a third option is to have south end on the upper left 2 and 1, upper left 2 and 1. So this will not interfere with the movement of the upper right 2. So south end can be used 0.7 millimeter stainless steel wire. Posterior biplane is used because the movement is interfered by the occlusion. So this is a T-spring and the Z-spring, just for you to see the design. So this is the patient before the treatment, and this is the patient after correction of the crossbite. Distalization of the buccal segment, an example of using expansion screw to distalize the buccal segment. So this is a little bit complicated case, but it's a good idea to look at different aspects. Of course, ideally, we would treat this patient using fixed appliances, but let's assume that the patient said, I cannot afford, for example, fixed appliances. And let's assume for the sake of the exercise that we want to correct this using a simple tipping movement and removable appliances. So the first problem is that I have both lateral incisors are in crossbite. I have lack of space and crowded upper left 5, and I want to correct this, okay? So what active components can be used? For the lateral incisors, I can use Z-spring on the upper right, 0.5 millimeter stainless steel wire, and another Z-spring on the upper left, because these are not two adjacent anterior teeth, they are separate. Okay, so I cannot use a whole long Z-spring for both of them. I have to use a Z-spring for the left side and another one for the right side. So what about the buccal segment and lack of space? Well, I can use an appliance that would distalize the buccal segment on the left side, and this can be achieved by expansion screw. What about palatal finger spring? Well, I don't have a single tooth. I have two big molars, so it's like a block of teeth. Two big molars, multi-rooted. So I need heavy force. So a palatal finger spring will not be enough, will not give a successful result. So this is the lap form. I choose Z-spring on both lateral incisors separately, of course. And I distalize the buccal segment by cutting the acryl here and adding my expansion screw there. And now, since I decided on my active components, I need to design the retentive components. Now, Adam's clasp on the upper left 7 is of course an option because, as I said, an expansion screw does not prevent us from using retentive components on the active unit. So I'm cutting the acryl here, I'm using expansion screw here, but still I can use Adams on the 7. It's difficult to use Adams on the 6 because the arrowhead and the retentive arm comes in the same exact place where the acryl is cut. So we will have weak area of acryl and it might fracture. So the 7 is a better option as long as it's fully erupted and we have undercut. We can use C-clasp on the upper left canine. On the right side, I use Adams on the 6 of 0.7 millimeter stainless steel wire and Adams on the 4 of 0.6 millimeter stainless steel wire. So these are 4 points of retention. 4 points of retention, of course, because my movement will be interfered with occlusion by correcting this crossbite and moving these teeth distally. I have to use posterior bite plane, not anterior bite plane, because the overbite is average. Actually, it's reduced. For this patient, it's reduced, so I cannot use anterior bite plane. So Z-spring, expansion screw, retentive components on the 7, on the left side, 0.7 millimeter stainless steel wire, on the right side, on the 6.7 millimeter stainless steel wire, C-clasp. As you can see, there is a little bit of space between the 3 and the 4, so I can use C-clasp on the 3.7 millimeter stainless steel wire and Adams on the upper left 4, 0.6 millimeter stainless steel wire. Can I use south end? Well, this is a little bit tricky because it will interfere with the tooth movement. If you use south end here, it will interfere with the tooth movement of the lateral incisors as they are being corrected. posterior bite plane to disocclude the teeth is a must. So the second stage, once you open the space, so let's say that the appliance was a success and you opened the space for the 5, then the second stage removable appliance is to push the 5 across the bite and correct the crossbite there. So you can use D-spring, and we can use Adams on the 7, again, so that you don't interfere with the tooth movement, Adams on the 6 on the other side for retention, and labial bow for anterior retention. Because you already corrected the anterior crossbite, you can use a labial bow. Of course, alternatively, now don't use labial bow and use Adams on the 4. This is an alternative design. And of course, the posterior bite plane is a must to disocclude the teeth and allow tooth movement. This is the alternative. As I said, we can use Adams on the 4 instead of a labial bow, and really the patient will appreciate it from an aesthetic point of view. So this is an expansion screw to distalize the buccal segment. Again, this is after expansion. So this is distalization of the buccal segment. T-springs on both lateral incisors because they are separate, and we have the T-spring on the 5. So just to remind you of the design of the active components. Other commonly used removable appliances is the one that we already talked about, a removable appliance that can help attachment to extraoral appliances. We call this in-mass appliance. In-mass appliance. In-mass appliance means a removable appliance plus face bow. This is a face bow. So this piece of wire will help the patient to connect the headgear, extraoral appliance, the headgear intraorally. Okay, so a removable appliance incorporated with a face bow is called in-mass appliance, and it is used to transfer forces extraorally to the intraoral components, and usually it is used to distalize the buccal segment. Right. If expansion is required at the same time, then we can use something called coffin spring. So this is a coffin spring, and this is the active component. This is an expansion spring. It's a heavy wire. The acryl is cut in the middle. We activate it like this. So we activate the appliance. We push both parts apart using our hands, and then we fit the appliance inside the patient's mouth, and it's supposed to go to produce expansion. And then if you add the face bow, then it is coffin spring and in-mass appliance at the same time. Nutter appliance is an appliance that is used to aid the distalization of the upper molars, and it's not used alone. It should be used with the headgear. So what happens is that the headgear produces the active distal movement of the molars, and the nutter appliance is used to maintain and prevent relapse during the day, because the patient cannot wear his headgear full time. Usually he wears it 14 hours out of the 24 hours. Now, the nutter should be worn full time, and it is used, as I said, to maintain the progress that the patient had with his headgear. The main active components are palatal finger springs. If you're distalizing both, we use palatal finger springs on both of them, and it is made of 0.5 millimeter stainless steel wire or 0.6, because again, this is not a real active component. It's just to maintain, to prevent relapse. Okay, because if you use a heavy wire and activate the distal, the palatal finger spring, the action is to distalize the molars, right? The reaction is to push all these teeth anteriorly. So you will lose anchorage, and the patient will end up having an increased overjet. So you need to let the headgear do the job, and then dust the palatal finger springs to maintain the progress and prevent relapse. So you can use the palatal finger spring on the molars to achieve this aim. And the rest of the components are mainly just retentive components. You can use Adams, you can use south ends, it depends on the case. And of course, the 6s are usually having a band, and the band usually has a special tube for the headgear. So 6 is having a band with a headgear tubes. The patient should use the headgear evening and nighttime, and the nudger should be used full time. The palatal finger spring should be lightly activated, 1 to 2 millimeters, 0.5 or 0.6 millimeter stainless steel wire. An example of the use of nudgers. So this is my patient, 12 years of age, a classical class 2 division 2 malocclusion. You can see the molars full unit class 2, quarter unit class 2, and very, very deep overbite. So my aim is to use headgear to distalize the molars. So we used nudger appliance. As you can see, there is a band on the 6th and the band on the other 6th, and then I have palatal finger springs on both sides, lightly activated to allow prevention of relapse. Okay, the rest of the components are for retention, and you can see that we used flat anterior bite plane at the same time to modify the appliance and reduce the overbite as well. So if you look at the molars, they are overcorrected on both sides. They're almost class 3. And who's doing the job by distalizing the buccal segment is not the removable appliance, it's the headgear that the patient is wearing evening and nighttime only. So this is to continue treatment. We fitted fixed appliances. And this is the molar relationship, a little bit overcorrected, quarter unit class 3 on both sides. And this is the patient before and after. So just to show you how we use nudger appliance in to correct a certain type of malocclusion. Thank you for listening.